we're going to look at a little bit of different angle. I'm more interested in a population level response to immunotherapy. And two things we are looking at is why there is different access to novel treatment. And it's one thing we see constantly when there is a new drug, the disparities widen. There's more gap instead of increasing the chances of people being treated. And the other thing I'm interested in is why the response to immunotherapy differs. It's not the same across populations. And what I'm going to show you today is something about the interference between immunotherapy and antibiotic treatment. As I said, we are interested in differences in response, and the antibiotic is a very good example for several reasons, because these patients with lung cancer have a lot of other comorbidities, especially lung comorbidities. So they're treated with antibiotics a long time, many around all over. And that modifies the microbiome in the gut. And some of the bacteria that are there favor the response, immunogenic response. So at the end, these bacteria become less diverse, less responsive to the immunostimulus, and then the efficacy of the immunotherapy, it's lowered. So the first thing that we did when this concept came up about the interjection between the two, we just look at the publications, and we are not going through all this, but we had to do a lot of work to weed out all the abstracts that never ended up in a publication. So we came up with a list of articles that were actually peer-reviewed and published. And to give you a summary of this, we basically found 14 studies that were published, roughly 2,000 patients. But the problems was that the lung cancer was at various stages in each paper. The lines of treatments were very various. Sometimes immunotherapy was used as first line, in combination, with a lot of variation in the regimen. And so was in the antibiotic, with different type of antibiotics, different rounds, different time in relation to the immunotherapy treatment. Another issue, the time frame was between 2011 and 2020. So some of the publications were on the clinical trials for registration of immunotherapy. Some others were observational. Same was the treatment, the immunotherapy brand and drug was different. But despite all this, we observed that 9 of the studies showed that overall survival and disease-free survival was lower in patients treated with antibiotics. And 9 studies had a multivariate analysis, so had the data adjusted for comorbidities, age, sex, and all the things that are important. And 8 of the 9 multivariate analyses confirmed that antibiotic lower overall survival and disease-free survival. We didn't go? Okay. And this is how the studies look like. You see, the dot is the survival estimate, and then the confidence interval. So the studies are very, very different from each other. And when we try to do a summary estimate, a meta-analysis, you see the red circle. That's the summary estimate. It shows a decrease in a significant decrease in survival, increase in mortality in using antibiotics. But the heterogeneity is so high that the program doesn't even allow to put confidence interval in because the variation is too wide. So really, these studies are not comparable with each other. We then did the same thing with disease-free survival, less number of studies. Again, it's very various big confidence interval from each study. And when we try to do the summary estimate, again, it's a significant association between worst disease-free survival and use of antibiotic. The hazard ratio is 1.3, you see it here. But the variability, it's so high in heterogeneity that it was really a meaningless estimate. So what we start doing is we start looking at our own data. We looked at CO Medicare. So CO Medicare is the claiming data from the US from Medicare for patients over 65. and connected to the cancer registry with the SEER data. So we took a stage 4 lung cancer starting in 2015 when we started having data on immunotherapy, with some adjustment with what the coverage was to be able to get the treatment around the diagnosis of lung cancer. And we look at patients who received immunotherapy alone or in combination with chemotherapy, and then whether they were prescribed antibiotic 2 months around immunotherapy starting. So we had 72 patients with antibiotics, 65 not. And already this is like a national database. We're coming down to such small numbers, unfortunately, even when we look at large data. And then we, hold on. Yes. So we look at survival. And so our first curve here is antibiotic, yes or no. No difference in survival estimate. It's antibiotic 2 months before versus 2 months past the start of immunotherapy. No significant difference. So we did a round of antibiotics, so no antibiotic, 1 round, more than 1 round. Again, basically no significant difference. So we try all the ways we can see if there is any signal. And then we did a multivariate analysis. So we adjusted for age, for sex, for comorbidities. And in red, you see the association between survival and the use of antibiotics. Basically, they're all non-significant. There is really no signal here. And this is a kind of a nationwide population sample. So it's kind of a good, as good as we can get data set. So up to this point, we really didn't find any association between survival and antibiotics, antibiotic times around immunotherapy, a number rounds of antibiotic, and even adjusting for the usual confounder. We didn't have enough data to look at progression-free survival, and we have not looked at type of antibiotics yet, because this was just done recently for this meeting. It's not out yet. And these are the people who worked on the data set for me and with me. So thank you.